Okay. Can everybody hear me and see my screen?
Yes.
Thank you.
Yes.
Please forgive the fact that I know that I post these all on YouTube, but I haven't done in a little while. That's purely just because it's completely slipped my mind, but I'm going to be uploading them all tomorrow, including this one. So your case for today. This lady is a Gravida 1 Paranaut, BMI of 28. She was low risk at booking. GTT was normal, anomaly scan was completely normal. This woman was low risk. She was due to deliver on the birth centre and she was booked for an outpatient induction at 41 plus 5. At 41 weeks, she had a sweep and her pre-fetal heart rate from the sweep was 138 and her post was 145 with an acceleration. This was done, but I believe it was done on the birth centre. She was booked for an induction as an outpatient, but she actually came in that morning and she'd been contracting overnight. So she's had no CTGs previously in pregnancy. Everything completely low risk. The only thing obviously is we've got to go off of is her previous fetal heart rate, 41 weeks was around 145, which you could kind of argue is a little bit raised considering the gestation, but normal for her in terms of the pattern of her fetal heart rates throughout pregnancy. So she comes into triage on the 23rd of the month. They triaged her on the birth centre because the plan was obviously if she was going to be in labour, then she could be cared for there. The midwife that did her examination and triaged her found the fetal heart rate to be 170 prior to VE. Did an examination at 11:05 and her cervix was 2 centimeters dilated, still with some thickness. Post-fetal heart rate was 160 beats per minute. So due to this, they kept her there for a little while. I think they hydrated her, just did a few additional auscultations. I'm not sure if they recorded any. And then they rechecked it at 11:40 and the fetal heart rate remained 170 beats per minute. So they recommended a CTG as they were unsure if the fetal heart rate included accelerations. And she also had some paracetamol at that time too. Her observations were done, as you can see, all normal. Blood pressure 129/82, pulse of 73, resps of 18, and SATs of 100. No temperature was recorded. I'm not sure whether it was done or not, but it wasn't recorded on Cerner. So this is essentially her assessment. This is her initial CTG in triage. So the midwife at the time was discussing this amongst the midwives in the unit, sort of saying, I think she needs to have one. And she agreed to it at that time. And it was obviously quite high. And this is the first sort of 40 minutes that you can see here. The registrar was informed to come and do a review at around 12:24. And she declined a cannula at this point as well. I think the reason for a cannula was possibly to give her some sort of hydration. I don't think she was particularly well hydrated at the time, and essentially see where we go just due to this CTG. So what do we think about it? This is quite a short case, by the way, guys. So the more discussion in this segment, then the better, really. What would we do if this was the CTG that we came across?
Looks like chronic hypoxia.
Yeah, it does. The raised baseline for gestation. So we know that obviously the later on a woman is in pregnancy, so the later gestations, we would expect the fetal heart rate to be a lot lower than 140, 150, considering the parasympathetic and the sympathetic nervous system should have matured pretty well at this point. So I would expect, this is please, if anybody else has any opinions, I would expect somebody that's 41 weeks and 5 days to have a baseline rate that's almost certainly under 130. Although there's no guidance to suggest, okay, yeah, she's this gestation, so it should be between this and this. Our general rule of thumb is between 110 and 160, but what does that really mean? I'd expect somebody that's 41 plus 5 to have a baseline of probably under 140, at least under 130. So what are we going to do with a chronic hypoxia?
She's not fit for labour. I think that's what you have to ask. She's not fit for labour. She's 2 centimetres. You wouldn't want to continue with this CTG, so potentially offer cesarean section.
Yeah, she's contracting sort of 2 to 3 in 10. They are strong on palpation, and she's breathing through them beautifully well, but she is in a lot of pain at this time as well. So the thing that makes me think, what else could this be, is the fact that with chronic hypoxia, normally that's as a result of something that's happened antenatally, not necessarily like labour induced, if that makes sense. And this woman's been contracting overnight, and it's now sort of 12 p.m, which makes me kind of think, okay, are we possibly end stages of a gradually evolving, like we've gone past the D cells, we've got to the point whereby the baseline's risen and the variability is reduced? Or could it be something like placental insufficiency? Because we're looking at this, we've got significantly reduced variability. It's very much less than 5. If we're asking ourselves the question of, is this baby fit for labour, we're going to say no. We're not going to add any additional stress to this baby, but we know from what's been going on so far in her labour that this baby is already showing us signs of distress. So the registrar was informed to come and review at 12:24, and they did. And this is the CTG continued. Go on,
Sorry,
Mr. Nagib,
Cara,
sorry.
sorry. The previous CTG, you said what we know so far from labor. I thought you said this is the first CTG, isn't it?
Yeah. But what I mean is, obviously, we don't know what's been going on, obviously, in utero since she started her labour. So she started contracting the night before. And obviously we don't have any reason to believe anything like went wrong in that sort of period of time. But it's just interesting that she's come in with this after she's been contracting for about 12 hours.
Right. I mean, also, I slightly differ from what Sorsha said, that we should offer cesarean now, and that we should judge immediately that the baby is not fit for labor. What we have so far is, I don't know, 30 minutes. I can't say that I'm happy with the CTG, definitely, but I cannot like say that not fit for labor from that only. Yes, so I need to have a little bit more. So I wouldn't have jumped for cesarean immediately. I would, yes, definitely, but in my head, yes, but at the same time, I need to see a little bit more.
Perfect. Thank you, Mr. Nagib. Also, when it comes to sort of classifying these CTGs, it's all well and good giving them a label and whatnot, but we're always looking at what's going on behind the scenes, if you like. If we think about it, this woman isn't actually in what we would call active labour just yet, but she is contracting regularly and she has got herself to 2 centimetres. We would consider this to be whatever you want to label it as, but significantly abnormal if this baseline variability is reduced for more than a period of 50 minutes. You've basically got just under 40 minutes here, and then this is the CTG continued. So the registrar came in at 12:30, was happy with the CTG at that point, and the plan was to admit this lady to antenatal ward for repeat CTGs. So that's what happened. She was taken off at 13:03, and then she was admitted to Hope ward. The reason that I found this case so interesting was because we've put a woman on a CTG. And if we're talking about it in terms of different types of guidance, we're looking at this CTG and we're saying, okay, we've got reduced variability, we've got no accelerations, we've got no decelerations, but we've got nothing that's really reassuring. So if we're happy with that CTG, we've got a low risk woman who's had a supposed normal CTG. Why can't she go home?
Is she reporting fetal movements at this point, by the way?
She is, yeah.
She is. Good fetal movements.
She was reporting fetal movements here, and you can see there's like the 2 dash lines at around 12:05.
Right.
Because she was given the clicker for this point.
But my thought point. But what you're saying in regards to sending them home is, I think from my own personal experience and previous experience, probably from other clinicians as well, is we've all been burnt by something similar. in potentially, we've heard of a case where we've sent someone home with this sort of CTG. We can't use Dawes Redmond because she's contracting, but we're also in that grey area where the CTG is not 100%, but it's also not bad enough for us to do anything about. So you're in that grey area again, and this is the issue. And I think there's some research out about this. Is actually this is a difference between antenatal and intrapartum CTGs, and actually the antenatal point of it is, what are we trying to prove here? Are we trying to find out hypoxia like an intrapartum, or are we trying to have a, because otherwise we'll put everyone on CTGs forever, won't we?
Yeah. And also this was a conversation that I had with the obstetricians at the time as well. We're classifying this CT, she's 2 centimeters, so technically speaking she's not in labor, and therefore this is an antenatal CTG, and therefore this makes this an abnormal antenatal CTG. Whereas if she was in labour, we'd call it something completely different. So where does that grey area lie? She's clearly having contractions that have made her to be 2 centimetres. She's a primip. So she's gone from having a posterior long closed cervix to obviously now having a 2 centimetre dilated one. So something's helped her to get in, the labour has caused her to progress, but she's not classified as labour. So where does the grey area end and start? And how do we rectify it? And what guideline can we use to rectify that? But at the same time, no matter what you're calling this, if you've got an abnormal antenatal CTG, you do not want to put that person with this abnormal CTG on the antenatal ward, whereby the ratio of women is 1 midwife to up to 8 women. But it's not normal enough for her to go home. It's normal enough for her to be an inpatient. But if you classify her as having an abnormal trace, then surely she should be on labour ward. So this is why I like this one. Does anybody else have any opinions on this, just out of interest, as to where they would prefer this patient to be?
I would personally prefer her in labor ward as well. I have my personal opinion as well about active and inactive and latent phase and all this demarcation. These are demarcation out of our, pure classification and pure like wanting to put demarcation on things. When, to be honest with you, my 2 centimeter can be your 3 centimeter. I mean, this for me is a lady is contracting, full stop. We don't have to do active labor and not active for me. Number 2, the clinical picture here is telling me, yes, it is abnormal CTG, but if you want to say significantly abnormal, I wouldn't say significantly abnormal, because suddenly the abnormal becomes significantly abnormal and insignificantly abnormal. Again, 30 minutes is not enough for me to say it is significantly abnormal. Fit for labor or not fit for labor yet, again, it is not very well demarcated. Not again, the question that Sorsha asked is very good question. What do we want to prove? In my opinion, here we don't want to prove anything yet, but we want to do the C-section in the right time and in the fullness of time, as we say. The fullness of time is, I don't want to differentiate between, let's say this woman is BMI of 50. We would be sitting here and saying, oh, we don't want to jump in and not wanting to do cesarean section. If she's a BMI of 18, we are very happy to jump in quickly because, like it is easy access. I can put a knife in and get the baby out in 1 minute. So I want to jump in the right time, and wanting to have a little bit more, to have more information, especially as you said, with a woman who is reporting fetal movement with a CTG that has not been long enough, with like I haven't seen meconium, I haven't seen something. So I wanted a little bit more information to put inside the picture. I haven't seen yet the corner of the picture or the middle of the picture. I need a little bit more.
Perfect. Thank you, Mr. Naguib.
Cara, sorry, just to interrupt. How many weeks is she?
41 plus 5.
So would you potentially think about, just as something that we're doing in our trust at the moment, is if she's coming in 2 centimetres, we could potentially talk about an ARM. I know she's contracting, she's making progress, but it's that discussion, put her on antenatal ward and potentially with a plan for ARM later on if she's had no progress. Would that impact on this CTG? I'm just throwing it out there, by the way. Just
so you're jumping ahead of the gun here, Sorge, because if you give me like another slide, you will figure that one out.
Sorry.
Anyway, she goes to antenatal ward, and the midwife puts this CTG on at 2 o'clock. So it's been about an hour she's had to rest, right? Also, at this point, this woman is very much a case of okay, but why do you keep putting me on a monitor? Like, if there's nothing significantly, this is also we've got to consider when we talk about the whole clinical picture here. This is something that we've seriously got to consider. We've got a woman who we keep putting on a monitor, but we don't know why we're putting on a monitor, because we don't really know what information we need to give to her additionally. The midwife at this point on our antenatal ward, on Hope ward, puts this CTG on. Obviously, you can see there's quite a lot of loss of contact here. This woman was moving around quite a lot in the bed, obviously because she's in pain, but her contractions had died down, which kind of to be expected when you're moved to a 6-bedded bay. At this point, the CTG is brought to the consultant for review by the Hope ward midwife, and then the consultant says, okay, let's bring her to labour ward. We then had a slight issue whereby the patient didn't want to come to labour ward because she didn't really know why she was being moved to labour ward. So that conversation then had to happen. The consultant on call explained the concerns and explained that we are concerned about the variability and therefore need to continue this CTG. And at this point, we're suggesting an ARM. The risks of no admission to labour ward were explained at this point, and then the client said, actually, no, I still don't want to come. But then also, what risks are we associating here? Are we saying this again? We've still got no classification. We still don't really know a lot more information other than the fact that we've had a baby with reduced variability now since 12 o'clock. And we don't know why. So the plan was to bring her to labour ward for an ARM. Now, myself and Miss Naguib have probably had about 12 chats about this, and had discussions on numerous occasions about the fact that when it comes to doing an ARM, if you are doing an ARM for inducing labour or to check what colour the liquor is, realistically speaking, there's two sides to this story. One is, if you perform an ARM on a baby that you think may be hypoxic and you think may be in distress, an ARM has the possibility of adding additional stress to the picture and then will progressively get worse. So for that side of things, you'd think, okay, I don't want to do an ARM on a woman that I know the baby could possibly end up worse as a result of it. But then you've also got the argument of, if she's ARM'd and there's meconium, for example, you know more about the clinical picture, and then you've got more means for a reason to escalate this into something like a cesarean section. But my question is, regardless of whether you know the liquor colour or not, you can clearly see that this is abnormal. So should that really change your plan of care?
I'm going to jump in, and the reason being is because of the conversation we've just had about this grey area, because we haven't got that decision of, yes, I'm going to cesarean section right now because I'm worried. It's that middle ground again where we're not too sure. And I think by doing an ARM, I think a lot of the time it makes us realise, okay, fine, we've made the right decision, because it's that grey area again. You do a cesarean section and you think, did we have time? Could she have potentially laboured? Or do we do it and do something, intervene, do an ARM, and then actually we've proven our hypothesis right? Does that make sense?
Yeah.
Because I think this is that grey area. I think there does need to be research behind this, because we're still using CTGs in sort of a wrong way in theory, because we should be, like you said, that whole clinical picture, because the baby's telling us something, actually the whole clinical picture might be telling us a different story. She's post-dates, the high baseline, but also she's labouring. I don't know the answer, but I think it's that grey area, which I think is why we potentially do the ARMs, but also why we might section and then have that answer of, oh, the APGARs were fine, the gases were fine. It's that middle ground. Nagib might be able to give a better answer, but I think that's one of the reasons why, essentially.
Yeah, I mean, Sorsha, you are absolutely spot on, because again, we are put in a situation where we are ridiculously non-knowledgeable people. You know, like the baby is doing like for us a check for our queen, and I have 1 or 2 moves to do. I have not got like many moves to do. I have 1 C-section and 2 is ARM, and not much to do at 2 centimeter. I don't have an instrumental. I don't have manual rotation. I don't have much to do. Am I 100% sure that this baby is telling me I am hypoxic? Personally, I look at the CTG and say, not really. I don't know. I feel like I am maybe 50, 60% thinking of that as an outcome at the end, but I'm not sure at the moment. And I do it. And with the rare circumstances, this lady had a bowel resection in the past or whatever, and I do the bowel injury, and this falls in the hands of an expert, and the expert says, oh, actually you jumped in too early. So to be honest with you, in this specific situation, I feel I am the only move that I move one of my like chess pieces is to ARM. I don't have any other options to be like putting the icing on the cake and say, okay, fine, yes, it is a C-section. It's obvious. But I do the ARM. So similar to what we said, I wouldn't transfer her to Hope Ward. No, I would get her straight away to labor ward. In labor ward, I would do the ARM and stay in the room. I wouldn't go. I am talking to this baby to know exactly what he or she wants me to do. I cannot trust this CTG to go outside my hands.
Mr. Nagib, I completely agree with you and with what Sorsha said, because of how grey this area is, and like if I want to do like the very old-fashioned pattern recognition, I'm going to put all of my money on this is a meconium trace, but only because it still falls in those sections that we still did not kind of like put physiology label to it, because we still do not know exactly when you have a stable baseline, let's say, and just the variability, which is an issue here. So I completely agree with ARMing only to support your decision of not taking her for an immediate section and not the other way around. So I think just because we can't really at this time explain what happened to the baby, this looks like an old insult, old injury, not hypoxia talking, and this is why I think by ARMing her we might gain more evidence to what is the baby telling us through the CTG. So yes, I will also go for ARM.
Can I ask, Maya, if this isn't, if you're questioning this being an old insult, would you then assume that this is a possible chronic hypoxia?
So this goes with what the gray zone, which I think this is a meconium, but obviously we still don't have a label for it. It's like, you know, when we started kind of discovering chorion CTG, to me, every time I see this trace, my brain is telling me this is meconium. Where is this meconium? Which means that the baby had something, and the baby had meconium. This is what my brain is saying. I don't know this case, so I'm very eager to know what's happening, but only because it's still that zone which we haven't had discovered completely. Because to me, this is only reduced variability. I've missed that beginning, so I don't know if she's on any medication which can explain that.
No, she's 41+5, Maya, completely medically low risk. Last scan was her anomaly, which was normal. Was booked for an induction at 41+5 as an outpatient, and she's come in at 41+5, and this is what we're looking at. She's not started induction. She came in contracting.
This is only a variability issue, which we can't really explain why this baby, sympathetic parasympathetic system is kind of giving us this variability. So always I think when I see something like this, it's I think of Meg the first thing. I don't know. We'll see.
I think you are right, and I think it's putting it back, physiology back into it. Anyone that's sort of over 41 weeks, I think having the physiology of meconium anyway, and most CTGs you think with post-dates potentially there's a meconium because of the post-dates rather than potentially an insult. But you mentioned it earlier, Cara, about the communication with the woman, and this is something we're trying to focus on in our induction labour, is actually giving the woman back her birth a little bit and actually having that discussion with her about what we think and actually what she thinks she wants for her birth as well. We're obviously discussing the ARM cesarean section, which we want to from a medical point of view for this CTG, but actually her own perception of her own body and her own labour can actually have an impact, that choice of the woman as well. Yes, they don't have our knowledge and they don't, but that's the point of the informed consent. And I think potentially if she opted out of the ARM and said, oh, let me see if I can do this on my own, that might change our own findings of how we're interpreting the CTG, because we may be more cautious because of the meconium, because of the risk factors of the variability, and actually would we intervene a bit more earlier? Would we offer that cesarean section earlier because of her choice? So I think it's really important about the communication of the woman as well, and actually how that can impact on the care that we provide. I'm just throwing it out there.
No, absolutely. I totally agree. But no, the communication was that we need to bring you to labour ward because we're concerned for your fetal well-being. And then she did end up coming. So this was her CTG on labour ward. She agreed to a cannula.
I think the other thing that Naguib always taught me and will stay with me forever is the train analogy. When a woman's contracting, you perform an ARM and the train is running at 30 miles an hour, and then once you do an ARM, it will go at full speed. And I think that's something that we have to consider with this woman as well, is she's contracting regularly, and actually if we do an ARM, it may impact even further. So having that discussion with her about that.
Do you want an IRM? Everybody want an IRM? Anybody have any counter argument?
So what I want to ask is, if after 40 minutes of trace, all what she agreed for is a cannula.
Yeah.
Right. Okay. So I'm not sure even if we suggest a cesarean section, she will agree. It is a, yeah. Anyway, yeah, we'll see.
Sarah, up until this point, how many hours of trace have we had with really reduced variability?
4.
And that's cycling as well, but I haven't seen any cycling.
Nope.
No.
No cycling.
With my with my hat on, I'd say, we see normal cycling. We would hopefully after 50 minutes you would get that active part. We're at 4 hours, where overall the variability seems to be below 5. And I would be really worried about what the effect of an ARM would do, especially already when she's having quite good regular contractions.
So would I.
Yeah, so I'll probably be on the no side of things.
Thank you, Katie. Can I ask if this CTG got him better, would we be then reassured?
Oh, now you're asking.
Yeah.
No, not at all, because we can't just disregard the last 4 hours.
Yeah.
And a CTG wouldn't just get better. I think that's our knowledge from physiology as well. A CTG just doesn't get better. And if it does, that warrants even more investigation, I think.
Yep. So so then the discussion is being had. So basically what's happening on labour ward at this time is we're all having a bit of a debate as to whether or not it's appropriate to ARM this lady. Her blood pressure is now 130/88, pulse is 90, resps of 20, sats of 99, and a temperature of 36.0. I would assume that those respiration rate and her pulse rate has gone up, probably slightly due to anxiety and the fact that she's come into labour ward, contracting, expecting to go to birth centre, and all of a sudden she's now on labour ward and we're querying whether or not to do an ARM or caesarean section her. So at this point, the midwife in charge goes in and has a really, really good and long conversation about what exactly is going on, why an ARM in this case would not be recommended, and basically goes and discusses all of the concerns that have been raised with this woman. And at this point, a caesarean section is recommended. This client wants a lotus birth. And this is when that information also comes out. So she's very keen to have a vaginal delivery so that she can have a lotus birth. But then the discussion is, can you do a caesarean section with a lotus birth?
Can you please, Clara, explain to everybody what is lotus?
I can.
Because till last week when you told me, I didn't know what is lotus.
So
I must admit.
lotus, yeah, absolutely. So a lotus birth is essentially where you do not cut the cord and clamp it at all. So the baby is delivered, you don't cut and clamp, you don't give any sort of drugs or anything, you just wait for the placenta to birth after the baby whilst the baby is still attached. A lotus birth as well, so some people might say, oh, that's just a physiological, or some people may call it physiological or not, depending on whether you classify physiology as when you cut and clamp the cord and then wait for the placenta, or whether you don't clamp it at all. But basically, when women have a lotus birth, this is normally due to some spiritual reasons. And a lotus birth, what they do is they keep the placenta attached to the baby until the cord falls off of the baby. So nobody touches the cord, nobody touches the placenta at all. And what normally happens is they wash the placenta and then they basically pack it, or they basically rub it with herbs and spices that you'd use to sort of season food so that it keeps it fresh and sort of cures it in a way. And the best way I can describe it is it's like the process of making something like salami or like a pastrami, that kind of thing. And that's essentially what lotus birth is. So this woman wanted to have a lotus birth with a caesarean section.
Sorry to interrupt
Clara.
here.
Sorry. Sorry.
Yeah, no, go on.
I'm trying to think just of the person who will kind of consent her for having caesarean section if she was going to go for salami placenta. How is that, like, we're giving her the extreme to what she's asking for, the extreme opposite. So I think, considering what you just told us, that kind of tells you what she's preparing mentally. So to take her this stage for a caesarean section, and even that some people might argue if this is a sectionable trace or not, is going to leave a couple really not happy. So I would second having a discussion with the lady about the concerns, and then I think offering, if she ends up having ARM and that really shifts the tilt, then she understands. But with this one, I don't know what you think, Mr. Naguib. Like, you know, she is really prepared to have everything normal and physiological, and then we're really distressing that image of what she's going to have, and that's going to really give her lots of anxiety.
But
Yeah,
also at the same
I
time,
agree with.
sorry, Mr.
Yeah,
Nagib, go
sorry.
ahead.
No, I agree with Maya, but at the same time, I would love to know who invented this lotus thing. Number one. Number two, why do we still want to defy all the animal kingdom, all the lions, the elephants, and so all the animals deliver and separate their babies from the placentas? Why do who is inventing and putting these ideas?
So
I can't. Yeah,
this actually, if you want me to be super specific, this actually comes from a practice. This is named after a woman called Claire Lotus. And essentially, it's come from the fact that chimpanzees don't separate a placenta and a newborn. So it comes
really.
from chimpanzees, but it's
Okay.
been and there's no research to suggest that it has any medical benefit on the mother or the baby whatsoever. There's nothing that's been clinically proven. But what it does do is it's essentially a spiritual thing. So they have like a ceremony when it comes off, the same way that we do get women that take their placentas home. Oh, that do take their placentas home and they bury them in the garden, or they do whatever they want to do with them. But yeah, that's where it's come from basically, and it just became very much a sort of spiritual act that some people decide to do.
I was just going to say, I understand, obviously, in her preferences need to try and be taken into account where possible, but I think it's again of having that real informed consent and really explaining, trying not to explain, obviously, saying being in too emotive way, that while her wishes would try to the best of our abilities to be respected, the how she might feel if, you know, if her baby was born, you know, really poorly, or even worse, to weigh that up into account, and that the overwhelming at this stage benefits of a C-section and the safety for her baby and possibly her outweighs that choice at the other end. I have to say, Cara, I really never thought when I was signing up for this today we were going to end up talking about lotus birth. I'm so glad I'm eating dinner at the same time.
Yeah, sorry, Katie. But something else I should also note is at Croydon we have no lotus birth guideline. So we have absolutely nothing that has any recommendations based off of lotus birth. We probably should add it in, but it's so uncommon that this happens. We see women take placentas home on probably a weekly basis, but when it comes to like lotus birth, this is not something that's even in our guidelines. So when we discuss this with the paediatricians, they also obviously had quite a significant input into it, because they were saying, okay, if there's ever any ascending infection in the cord and that goes into baby, unlikely because there's obviously no more blood flow, but if there's any ascending infection from the placenta through the cord to the baby, then they're going to have to detach them. So then we went through a vicious cycle of like, okay, well, if the baby develops an infection, would you consent to us cutting the cord? Anyway, the moral of the story was,
So, my question as well, I'm not sure, you know, I know we are deviating slightly. When the baby is born and fine and the placenta is attached and in the postnatal, or I don't know, the ward, uh, does this placenta get rotten and all the blood and the smell? And I don't know. I am just
so
asking.
because of the
Yes, it
fact that
does.
you pat it with herbs and whatnot, it just dries out and becomes sort of cured. It doesn't actually go rotten. Well, if it's done properly, it doesn't go rotten.
I've worked as a home birth midwife, and I can assure you it definitely does if it's not done the right way.
And I agree with you, Katie, to be honest, because I entered the sluice post when some of those placentas are left in, and the smell inside there is absolutely dreadful. And with all respect, of course, she can have her placenta with her and with her baby and with her husband and everything. What about the neighboring patient? I mean, I don't know. I'm slightly, overwhelmed, and I don't know where is this obstetrics going, in the future.
Mm. Right, we'll move on because I'm very well aware of the time, guys. So
Maybe we've lost situational awareness, Cara.
yeah, we have. So at 16:59, she is consented for a cesarean section. After a very long and very communicative discussion with all of the team. She was consented for by the obstetric registrar, who then performed the procedure. The woman was aware of the client was aware that the wishes for lotus birth would be respected as long as it posed no risk to mother or baby. So essentially what that means is they were going to attempt to do a cesarean section with a lotus birth, but if there was any concerns, then we were going to cut the cord, and she was made aware of that. This is theatre. 1801, knife to skin. 1806 delivery. She had 3 minutes of delayed cord clamping, and the baby and the placenta stayed together and were taken to the resuscitator.
You said delayed cord clamping. Do we still clamp the cord?
No.
So what is delayed cord clamping here?
So they're basically the delayed. There's a time delay before the obstetrician manually removed the placenta from the uterus.
Right. Yeah. So
Yeah.
okay.
So the baby had like 3 minutes where it was attached to the placenta and was probably still getting some blood, and then the placenta was manually removed. Now, I don't know of many people, and I have asked around, I don't know of many people that can say they witnessed a lotus cesarean section. But it
Well done
happened.
to that obstetrician. Yeah, well done to
I
them
mean,
for doing it.
yeah, I mean, it is nothing. It is nothing new. We can manually separate a placenta with anything. It is lotus is nothing. Is just it's nothing. Yeah, you just separated the placenta manually and left it with the baby. Yeah, it is. You haven't done really. You can also next time clamp the uterus and do a subtotal hysterectomy and leave it attached as well to the placenta. I mean, where will it stop?
I know. Obviously, we didn't get cord gases for this baby because all the blood was going to it. But anybody want to guess the APGARs?
No, normal APGARs, normal gases. 7.1, 7.18.
We've not got
7.
gases, Mr. Naguib. The placenta's still attached.
Oh yeah, sorry. Normal APGARs.
Perfect. Yep. This baby was born with APGARs of 9, 10, and 10. Weighed 3,945 grams on the 73rd centile. Obviously no gases because the cord was attached to the placenta. There was clear and non-offensive liquor at delivery, despite what our initial thoughts may have been. And she left before 24 hours because she was up and about, moving around, and wanted to leave the next morning. As far as I'm aware, I have chased up this case. As far as I'm aware, the baby remained attached for a couple of days before the cord fell off.
That's a really interesting case. Thank you for sharing that, Cara.
You're welcome.
Thank you, Cara. No comment.
Mum, baby, and placenta are all doing well.
Thank you, Cara.
All doing well, yep. And as far as I'm aware, there's no report of it being gone off, but we don't know. But yeah, I just thought that was a good one. So thank you all for your contributions. I've thoroughly enjoyed myself. Fab. Right, next week, guys, I'm on annual leave, so you've got a Tuesday off. But I will be back and ready to see you all again on the 14th of November.
Have fun, Cara. Enjoy.
Thank you.
Bye.
Thank you.
Take care.
Thank you.
Sarah.
Thank you.